Do you struggle with constipation, painful sex, or unexplained pelvic discomfort, and nobody is giving you real answers? What if the root cause was your pelvic floor? And what if healing didn't require surgery, but the right kind of education and support? Today, we're going to learn all about pelvic floor health from pelvic physical therapist and author of the book, Power to the Pelvis, Alicia Jeffrey Thomas. Welcome to Brave and Curious, the podcast where we do a deep dive into understanding fertility, reproductive health, and wellness with science and compassion. I'm your host, Dr. Lora Shahine, double board certified OBGYN and reproductive endocrinologist. Let's stay brave and curious together. Today, I am curious about pelvic floor health and wellness. I am thrilled to have Alicia Jeffrey Thomas on the show today. I have gotten to know her through her incredibly valuable and educational social media content. With over 1 million followers on TikTok and Instagram, she is teaching the world all about the importance of pelvic floor health. Her recently published book, Power to the Pelvis, is a beautifully illustrated and educational guide and instruction manual to understanding symptoms and treatment of pelvic floor health. Well, welcome to the show, Alicia. I'm so happy to have you here.
Thank you so much for having me.
We were talking before we started recording that I really feel like I know you, but you're just like a TikTok friend because I've followed you for so long and appreciate all the education that you give.
Well, thank you. No, it's been really cool getting to get to know other creators on the internet too that kind of exist in the same spaces. And you're right, it does kind of feel like we're friends because we speak more of a similar language than my friends that don't do things on the internet. And especially in, the women's health space, the reproductive space, there's a lot of just things that you get that, it's just unique.
Well, that's why I want to talk to you today, because so many of my patients can really benefit from understanding more about their pelvic floor health. And so tell us, Alicia, why does pelvic floor health, why does it matter?
It's so integral to so many things in your life that you may not even really realize. I mean, when people think of the pelvic floor, usually their immediate thing that they jump to is Kegel exercises, right? And they think, oh, postpartum, you have a baby, you're, peeing yourself, maybe you need to do Kegels. And that's 1% of what we've got going on in the pelvic floor. I mean, yes, the pelvic floor is kind of that, set of muscles that's holding up all your internal organs and opening and closing for bowel and bladder function. So that means that it can certainly play a role in urinary incontinence, so leaking when you cough or laugh or sneeze, or even when you're running to the bathroom and feeling like you're not going to make it on time. It could be a driver in, urinary urgency and frequency. It could be a driver in things like constipation or fecal incontinence. It can be a huge driver or a contributor in pelvic pain, which can be everything under the sun from, painless sex or tampon use or, pain related to conditions like endometriosis or interstitial cystitis. And a lot of times too, your back pain, your hip pain, there are pieces of that where the pelvic floor can really come into play.
Yeah, I love it. And I really didn't learn a lot about pelvic PT when I was in medical school, right? So a lot of the things that you just discussed was addressed in Western medicine terms. Like someone had pain, you think about giving them medication, or someone's having incontinence, you think about sending them to a urologist for surgery. And so I think that I have learned so much in the last 20 years since I graduated medical school, but I really want people to understand what pelvic physical therapy is, what that means and what you do to help people.
Totally. So, I mean, I am a physical therapist first, right? You go to PT school, you get trained, you get your doctorate in physical therapy, and you come out as kind of a generalist, and then you can decide to subspecialize from there. And what I like to make sure that I emphasize to people is that pelvic floor therapy still has all of those elements of regular physical therapy. It just kind of has a little bit of a twist to it. So we're still looking at, muscle strength, muscle range of motion. We're looking at kind of that dynamic function between all these different parts of the body. It's just we're adding in that pelvic floor, which is a part of the body that nobody thinks about. Nobody really knows too much about if you're just a layperson. And so, the biggest difference is that, if the person is comfortable, we're doing an internal exam to assess the muscles of the pelvic floor.
Yeah. What kind of training happens for somebody that's a pelvic PT? So you talked about kind of going to the training as a physical therapist and then subspecialty training. Can you tell me a little bit more?
There's a few different paths that people will take to that specialty training. So for me personally, I was able to do a full-time clinical rotation when I was still in school. So I took a course that basically kind of was like the 101 of the pelvic floor and how to do an internal exam before I ever did that clinical rotation. So then I had a few months of basically working in a mentored situation with a pelvic floor therapist, learning about all of these different conditions and how to treat them. And then, there's further coursework that you can take. I think the original series is like 4 courses, but then obviously you're like continuously taking courses and you're continuously learning. There are people that do residency programs. There aren't a ton of those out there. So that's definitely not like the only way that somebody can qualify. And then there's also people who, kind of do a combination of mentored approaches with, other clinicians in addition to taking the coursework.
Okay. And how do patients come to you? Like, do they get referred? Do they refer themselves? How do they know that you exist and that people in your field exist and that they should see you?
So this is something that's really kind of evolved as I've been working. So when I first came out of school, the only time that we ever saw people was they were referred by their urologist usually. And they would show up in the clinic and they'd say, I don't know why I'm here. Because you show up into a PT office that's got other orthopedic stuff going on in a gym, and I pull you back into a private room. I'm like, all right, so tell me about your pelvic floor. Yeah. And so this has really evolved because now we're starting to see, through social media, through increased, word of mouth about these types of topics, people are self-referring more. And so I am having people come in and say, hey, like I brought this up to my doctor. They didn't really take me seriously, or, they wanted to kind of like get around some of the hoops there. And so they're referring themselves for these issues that they've recognized in themselves on social media or their friends have talked to them about. And so I think that's really cool. I do also still get a lot of referrals from primary care physicians, from OBGYNs, from urologists, urogynecologists, colorectal surgeons. It's really just, finding that person that's going to see your symptoms and connect the dots to say, ooh, okay, like pelvic floor therapy might make sense here.
Yeah. And what are some examples of some of the things that you see or help people with?
So certainly, urinary incontinence is going to be the most common one, I think, that people are thinking to come in for. But then, like I said, like there's definitely that like hip and back pain related to either pregnancy or postpartum. There's, pelvic pain related to pain with sex. So you can see people where their pelvic floor muscles don't know how to relax appropriately in order to insert something like a tampon. And so we're teaching them how to kind of get in tune with what those muscles are doing and have them stop kind of involuntarily contracting when they're trying to put something in. And then, the other big umbrella is kind of the bowel issues, right? So, constipation, if you have pelvic floor muscles that don't relax appropriately, it's really hard to have a good bowel movement. So we work a lot with people, in terms of getting those muscles to relax. And then all of those things all kind of overlap. It's very rare that I see somebody for just one thing. They may think they're coming in for one thing, but then I'll start asking about all these other different umbrella areas and we'll start to find, oh, you have urinary urgency, but you also only poop twice a week. And it kind of just spirals from there.
Yeah. No, it's fascinating. I would say as a fertility doctor, I would refer mostly for pain with intercourse, vaginismus, where just really clenching of the pelvic floor with trying to insert anything into the vagina, whether it's a tampon or intercourse, endometriosis pain.
Definitely.
But I have to talk really quickly about your book, Power to the Pelvis, because I learned this is amazing. First of all, the reason I'm bringing it up now is because I learned so many unusual reasons or symptoms that people kind of should think about seeing a pelvic physical therapist, but just absolutely beautiful illustrations, exercises. This is what your poop should look like. And I for example, this is a great lead in. Like, what are some things that are related to your pelvic floor that people don't know? Like, I would have never, when you think about like constipation, I think about sending somebody to a GI specialist or thinking about, hydration and moving your body. But like, how is that related to the pelvic floor?
Well, and I'm also still talking about hydration and moving your body, right? Because you can still work on the motility piece. Maybe somebody has a lot of like abdominal gripping, and that might be kind of keeping things from moving appropriately through their system. So we are doing, abdominal manual therapy, or teaching them how to do abdominal massage, teaching them movement strategies to kind of help to get things moving through their system. But then also, you get all the way down to the bottom of that chain there, and it's basically, getting the exit doors to open. So if you have, infrequent bowel movements, or feeling like you're not emptying completely, or you have those really like skinny bowel movements, those tend to be those indicators of pelvic floor muscle dysfunction.
Okay. And other unusual symptoms that can be related to the pelvic floor?
Tailbone pain. Because people don't think about it, but your tailbone is kind of that back attachment point for your pelvic floor. And so a lot of times the pain isn't coming from the tailbone itself, but it's coming from, all of these muscular structures that are attaching back here. That could be driving some of that. And then the same thing with hip pain, because the pelvic floor kind of winds into where some of your hip rotators are. A lot of times, there have been multiple instances where somebody's seen a regular orthopedic PT for hip pain and they can't figure out what's going on. It's not getting better. I go in, I do an internal exam. I'm like, boop, there's your obturator internus. And they're like, that's my hip pain. So.
Wow. And then in your book, you said TMJ pain. Like what? Describe what that is and how that could possibly be related to a completely different part of the body.
Yeah. So TMJ pain, we're talking about jaw pain, right? And so a lot of times people will either voluntarily or involuntarily be clenching their muscles there. And that habit of clenching, or that involuntary pattern of clenching, can affect you body wide. So if you're clenching up here, you're probably clenching in your pelvic floor too. And so I've seen people where, we've worked on their jaw and done some manual releases there, and that's affected their pelvic floor. Or as we're doing pelvic floor work with somebody, they're like, oh, I've noticed that my jaw and my neck aren't hurting as much. And it's just this kind of like bodily awareness and like, releasing some of that tension there.
So basically, everyone should see a pelvic PT, is what you're trying to say.
Basically.
Basically. Okay, well, what's a new patient visit like for you? Because you said internal exam twice already, and I can see people sort of saying like, wait, what does that mean? And that seems kind of weird. And but there's so much benefit to it that I really want people to understand, and how you make people feel comfortable and really help them.
Totally. And I will say, like, right off the bat, the internal exam is never mandatory, right? It's an extra piece of information that's going to directly tell us, hey, what's happening here? But I'm never going to require that of somebody. I assume that most people that come into my office have some amount of a trauma history, or, some apprehension to doing this type of exam. And so I'm always going to walk them through, hey, this is what my ideal day with you would look like, but you can tell me what you're comfortable with. And at any point, you're able to change your mind, say, no, I don't want to do that. The normal flow of the visit is we start out and we're talking. For probably the majority of the visit, we're talking. And I'm asking all of those personal questions. When did these symptoms start? How do they relate to other areas of the body? And we're really trying to like nail down the details there. And that's to help me form hypotheses about what's going on, but it's also so that we can kind of track what's happening over time, and know as things are starting to get better, because sometimes that initial improvement isn't necessarily the most glaringly obvious symptom. You may be coming in for, pelvic pain as your main thing, but we've also found, after a couple of visits, oh, hey, I'm not going to the bathroom every hour. I'm able to hold it for a couple hours where I couldn't before, those kind of like interrelated things. It's telling me your pelvic floor is getting better. It's just not affecting that main symptom yet. And then usually what I'll do is some form of an orthopedic exam. So like I said, everything is related. Your pelvic floor doesn't just exist on its own. So I'm looking at your back, I'm looking at your hips, I'm looking at your abdomen, and I'm seeing, where do we have areas of tightness or weakness that might be impacting what's happening at the pelvic floor. So even before we get to this pelvic floor muscle exam, I'm already making assumptions and trying to kind of think, how is your pelvic floor going to present when I get there? If we get there.
When you do that, is it that you're doing stretching with them, or, like how do you assess orthopedic?
Yeah. I mean,
muscles and
I'll start out and I'll literally have them just move around. Like I'll say, okay, try to touch your toes, try to do a squat, try to stand on one leg. And all of those things, I'm using my regular PT brain, to try to look at, okay, if you're dipping to the side when you're standing on one leg, that's telling me that there's some weakness in that hip. Or, if you squat and you tend to shift to one side, that's going to tell me something. Or if you have pain when you're doing any of those movements, it's already telling me little bits and pieces about what's going on around the pelvic floor.
Okay.
The pelvic floor exam itself, if you have a vagina, we typically default to a vaginal exam. The only difference would be if you have a preference for doing a rectal exam, or if you're coming in for a, more colorectal problem. Like if you're telling me that your main issue is constipation, then we may want to go there, or tailbone pain, because that puts us a little bit closer to where those muscles live, right?
Yeah.
But there's no instruments, there's no stirrups, no speculum, no scary stuff. It's a single digit exam. And we're going through and we're kind of making a gentle map of the muscles to see, again, where there's tension and tightness, where there's, potentially some provoked discomfort, and then just how the muscles are able to coordinate and function. So I'll say, okay, try to squeeze, try to relax, try to bear down. And if your brain and your body are able to connect all of those things together, that's another kind of data point for me.
Yeah. Fascinating. And then what is treatment like? Like once you've made an assessment and you're working, I mean, of course it is going to differ with what you're treating, but
Sure.
just in general, let's say treatment for, pain with intercourse, like what would sort of treatment look like?
Yeah. So it tends to be a little bit more hands-on for something like that. Again, based on what the person is comfortable with, but usually we're doing some amount of stretching to the pelvic floor, and that can either be, kind of similar to that digital manual exam where we're finding a spot that feels maybe tight or tender and we're applying very, very gentle pressure. They're practicing some breathing and relaxation exercises. We may progress up to using something like pelvic floor dilators, which are here, hold on. I've got one. They're like cylindrically shaped devices that get progressively larger. And you practice being able to relax around that so that you can get to something that's the size of a tampon or a speculum or the size of your partner, so that you're not having pain with those activities.
Okay. Got it. And then does treatment also involve home exercises and treatment? Because there's a lot of wonderful tips in your book about some stretching and things you can do at home. So I assume you're, practicing between appointments.
Yeah. So, I will usually have people follow up any manual work that we do with movement kind of within that new range of motion that we've created, right? So they'll follow that up with, a stretch, or they'll do an exercise, a strengthening exercise within that new range that we've created. So those things can then go home with them and they can be practicing it during the week. I also teach them how to do some of the manual techniques to themselves, whether that's with the dilators or the pelvic ones, or even just using their own hands, again, depending on what somebody's comfortable with and what stage of treatment that they're at.
Okay. That's fascinating. And then just in general, how long do patients work with you? I mean, of course, it depends on their personal situation, but is it something that is, a couple weeks, couple months, couple years?
It's really going to depend. I mean, I certainly have people where I see them for 6 to 8 visits, right? And that kind of tends to be like your average. But if you have something that's a chronic issue that you've had for, 5-10 years or something like that, or even longer, it's going to take us probably more than that to start to undo some of that. And again, that's not to say that we're not going to see improvements along the way, but to get you back to that optimal function, it could take a lot longer. I have people who I've been seeing for upwards of a year. And those are people who maybe have, chronic pelvic pain, where maybe we've gotten them to where they're like doing pretty well functionally, but we've still got like some residual things that we're working on, or they have, a chronic condition like endometriosis or interstitial cystitis where they'll have, flare-ups of pain, and we kind of bring them in for like a tune-up visit, that they're then otherwise, using the techniques and the stretches and things that we've taught them to be able to do a lot of that self-management at home.
Okay. And tell the listeners what interstitial cystitis is.
So interstitial cystitis is basically, the easiest way to understand it is it's your hallmark symptoms of an overactive bladder. So urgency, frequency, getting up at night, but it's combined with pain. So that can be pain when the bladder is filling up, or pain when the bladder goes to empty. And a lot of times we see this alongside really tight pelvic floor muscles. So again, that like, okay, if we're in this chronic state of expecting that there's going to be pain when something happens, your muscles are going to learn that and adapt to that and shorten as a result, which is going to drive difficulty emptying your bladder, which is going to drive frequency, which is going to drive pain.
Mm-hmm. It's very cyclical and kind of builds on itself. I see that with my patients with endometriosis, chronic pain, that sort of things that might not be painful to someone without endometriosis, like you would think like, oh, that shouldn't cause that much pain, but their nervous system is just like, jacked. It's like so used to like being almost like in like fight or flight that the little things can really be reactive. And so are you trying to kind of reset the body a little bit to kind of learn how to relax or sort of get back to kind of a steady state? I don't know if I'm
you're saying that
right.
exactly right. Yeah, I tend to start with a very nervous system first approach. So, we're talking about all this like hands-on manual work and stretches and all that stuff. What I actually usually start with people is breathing, and making sure that they have the ability to kind of bring down some of that fight or flight, before we start laying hands on a person or having them move outside of their comfort zone. I want to make sure that we're not doing anything that's going to ramp that nervous system up and have them leaving feeling worse than they came in. And whether that's physically worse or just mentally and emotionally worse, because we're kind of, doing something that's new to them.
Yeah. Do you have a favorite breathing technique, like box breathing or counting or?
It's not necessarily for me about like the breath technique itself. It's more like, it's because it's going to like, I have to kind of flip through it with patients and be like, okay, what makes the most sense to you? Because there are some people where I'll say, okay, try to expand your belly, and they'll just like puff out their stomach, So, it's sometimes I have to really experiment with positioning for breathing. I'll have them lie on their side, or I'll have them get into child's pose. And I like working with that, like the movement with the breathing, where I'm completely hands off for the most part, and trying to get them to the point where they can connect with their body and figure out that relaxation piece.
That sounds really, really good. You're really teaching people about their bodies, staying connected, and, these techniques that they can do on their own, it seems like. I want to take a quick break and remind you just how important it is to support the show. Wherever you're listening, take a moment, rate, review, and especially follow the show. It helps others find this valuable information on reproductive health and wellness. Thank you so much for being here today. I hope that you are finding this information helpful. Now let's get back to talking to and learning from Alicia. Is pelvic PT something that insurance usually covers?
So it depends. I think it's getting better, right? But at the same time, it's really tough because, you have the insurance-based clinics, the clinics that accept insurance tend to get a much longer wait list because of that. Reimbursement on the provider side is not awesome. And so a lot of people have moved to an out-of-network model as providers. But also those same people can submit, if they have out-of-network benefits, they can get, 50 to 80% reimbursed on the back end, if they see an out-of-network provider. So,
okay, thanks. Yeah, I was just curious. It's a big, access is a big issue.
Totally. Which is, it's part of the reason why I wrote the book, because I see people that wait for, the local hospitals around here, I think the last time I was told was 9 months to get in.
Oh my gosh.
Which is just, it's unsustainable. How do you, as somebody who, is newly pregnant, you have to kind of be thinking, okay, well, right now I have to start making my appointment for when I deliver,
Yeah.
In order to catch up on time. Like that's not great. That's not a great system. And so we need more resources. We need people to understand what's going on with their bodies so that they can do some stuff at home and then, be able to get further resources, down the line when they need it.
Yeah. Well, I'm really glad that you wrote your book too, because you're so entertaining and educational on TikTok and Instagram, but I'm often like, wait, what? Because like in 60 seconds, you can't like learn everything. Like, like you teach people like, how to poop, right? Like how to sit and how to pee. And it's just like absolutely amazing. And so when I knew that we were going to be meeting, I reached out to my communities on TikTok and Instagram, and I said, hey, what questions do you have for Alicia? Let's like ask her. And it's really came to a lot of like myths, like myth busting. So I'd love to ask you some specific myths and
let's do it.
all about pelvic floor. Okay. So the first one, just in case peeing, you talk about that, or you like educate about this a lot. And what does that mean?
So it's basically going to the bathroom, just in case, when you don't really feel like you need to go, but you're about to leave the house. So you feel like you should try, or, oh, I just went 30 minutes ago, but I've been laying in bed here reading. Maybe I should try to go again before I go to sleep, different things like that. And what that's doing over time is that's training your bladder to not want to hold as much urine. You kind of get these normal levels of sensation of when your bladder, is filling up and when it says, okay, like maybe it's time to make a plan to go to the bathroom. And so if you're undercutting that and you're saying, okay, well, I'm going to, go here before I go to CVS or whatever, and we're doing that repeatedly, your bladder's going to think, oh, okay, well, maybe I should be sending that signal a little bit sooner. And then your just in case is going to try to jump in front of that. And so it's just kind of this self-perpetuating cycle that eventually ends up with us having, more urgency, more frequency, and we're kind of being ruled by these trips to the bathroom.
Yeah. I've talked to my patients about the bladder sort of being like a balloon, right? And so like teachers, nurses, doctors, like they often have this huge balloon because they've held it for so long,
right?
That their signal to their brain, like, oh, I have a full bladder, I should go to the bathroom, has just kind of been dampened for a while. And then you're describing this sort of opposite of like,
exactly,
you're training your bladder at a smaller level of fullness to like feel like it has to go.
Right.
And that's the harm of the just in case peeing.
And the same thing with the balloon analogy, right? Like your bladder has this kind of like, reflexive, like, okay, it's going to contract to help to empty everything out. If it's not getting like a good amount of expansion, it's not going to have as much of a force there to try to get that urine to empty. And so then you're pushing, right, to try to make that urine come out. And that's not great for your pelvic floor either.
Yeah. So how often should we pee?
So normal time between trips to the bathroom is going to be anywhere between 2 to 4 hours. And so, I tell people like, we don't want to be the occasional time that you find yourself holding for 5 hours or so because you didn't have access to a bathroom, like that's not going to kill you. But if you're, regularly in that like teacher nurse bladder where you're going your whole shift and you're not able to access a bathroom, that's not great. But also at the same time, we don't want you going every hour to hour and a half. Even my folks who are pregnant, we tend to want to try to keep them closer to that 2 hour mark, versus kind of letting it like spiral out of control and getting into this like, okay, I'm going every 30 minutes because even, yes, you're pregnant, you have more pressure being placed upon your, bladder and your organs and everything, but it doesn't necessarily always need to mean that you're going that frequently.
Okay. And what are little tips that you have for people that are trying to kind of, get that balloon to be a little bit bigger, for someone who, I bet someone who's listening just thought to themselves like, oh my gosh, I feel like I have to go to the bathroom every 30 minutes to an hour. Like even imagining 4 hours just sounds daunting. How do they get to that point?
Yeah. And I think, it's not going to be overnight. We're going to go from every 30 minutes to every 4 hours, right? It's going to be using different techniques and strategies to push it by 5 minutes or 10 minutes. And the point of it is that you want to be able to keep your nervous system calm as you're trying to, get that little bit of extra stretch and a little bit of extra time. So I'll teach people different urgency techniques using a lot of like belly breathing, using some mental distraction to try to kind of get over that initial wave of urgency so that they can wait it out a little bit longer. And then gradually your bladder adapts to that. You can push a little bit more, but it's something where you're kind of repeatedly doing it over time. And then the other thing too is to think about what you're putting into your body. So if you're drinking a lot of things that are irritating to your bladder, coffee, tea, caffeine, alcohol, carbonated stuff, including like seltzer water. Those things kind of make it a little bit more of an uphill battle because those are making the detrusor muscle around the bladder contract more. So we want to make sure that not that you can't drink any of those things ever, right? But like the ratio is important. Yeah. So I usually will tell people 3-to-1 water to everything else.
Okay.
And slowly sipping throughout the day so that you're giving your bladder kind of these normal signals of filling, and you can get these normal signals of when it's time for you to go to the bathroom.
Yeah. And then you talked about too, the little diaries. So you're like, honestly, like training yourself, like, oh, when do I feel like I have to go? And you're like, oh my gosh, I just went 30 minutes ago. So I'm going to try the breathing and I'm try to get to maybe 15 more minutes or something like that, and kind of keeping track, right?
Yeah. Bladder diaries are great for getting your baseline, right?
Okay.
Because a lot of times people will come in and I'll say, okay, how often are you going to the bathroom? And they're like, I have no idea. So I'll send them home, and it's, just a little quick spreadsheet, or they can just, write notes on their phone, when you go to the bathroom, what you're drinking during the day, and like how intense the urge is, maybe how much you're going. It's like, it depends on what we're trying to track, but I'll have them track a couple of different data points so that we know, where we can push it and where things might be okay, different things like that.
Yeah. Okay. Fascinating. All right. Next one. Teach us how to pee in a public toilet. Let's talk about hovering.
Yeah. All right. This is one of my favorite things to talk about, because I used to be like a supreme hoverer. Like, I don't think I touched a toilet in public until I was like 25.
Guilty.
And it's one of those things where it's passed down as, oh, well, you're, gonna get crabs. You're gonna get, something if you sit on this toilet seat, right? And there have been a lot of studies done, and it actually shows that the toilet seat is one of the cleanest surfaces in the bathroom. Especially if you look at it compared to like the stall lock or the faucet or any of these other high touch surfaces. And those are things that, like, it's getting on your hands, and your hands are going to go everywhere else on your body, versus your thigh skin, right? Which is not mucosal tissue. It's not going to get anything introduced to it. You're perfectly safe to sit on the toilet. And the reason that that's really important from a pelvic floor perspective is because if you're not relaxing, your pelvic floor is not going to be able to relax appropriately and get out of the way and empty your bladder completely. So then we're doing, weird compensatory things like pushing to go, which is, like I said before, weakening your pelvic floor, could be contributing to things like pelvic organ prolapse. So we really want to make sure that we sit. What you do in order to be able to sit, I don't care. If you want to wipe it off with a Clorox wipe or make a toilet paper nest, whatever makes you feel comfortable. But for the sake of your pelvic floor, I just want to encourage all of your listeners to have a seat.
Have a seat. Relax.
Yeah.
No hovering. Okay. I love that. Thank you. Okay. This, you're going to love talking about this. Kegels are great for everyone.
So
let's talk about it.
They're not great for everybody. Let's just put that out there. And I use the example of bicep curls. If you told me that every single person with a shoulder issue, no matter what was going on, they needed to do bicep curls, I would tell you, okay, that's silly. Maybe that's part of their rehab program, but it's not like the exclusive thing that's going to make them better. And I feel like that's kind of the energy that some people ascribe to Kegels is, oh, just do your Kegels and you'll be fine. When we know that the pelvic floor has this full range of motion of function where, yes, it needs to be able to contract, but it also needs to be able to relax. How is the pelvic floor functioning with your breath? How is it functioning alongside these dynamic movements like squatting and lifting and things like that? There's so much more that goes into it that you can't just reduce it down to just doing Kegel exercises. Also, most people don't do Kegel exercises correctly when they're just given verbal instructions. A lot of times people will try to use their glutes, their abs, their inner thigh muscles. They don't work on a combination of endurance and power. There's a lot of exercise prescription things that you wouldn't necessarily think of, but I'm thinking of the same way that I would prescribe a hip exercise or a shoulder exercise. I want to make sure that it's the right dosage, the right exercise for the right person.
Okay, that's great. And I mean, because that's what so many women hear. They go to their postpartum visit, they're having a little bit of leaking, and the doctor says, oh, well, just do your Kegels, and that's it. And they don't, and then they think, well, if it continues, I must not be doing them enough. And then can it backfire? Can't you stress your muscles?
Exactly. So because your pelvic floor needs to have this very dynamic up and down function, if we're constantly just clenching, we can kind of get it almost like stuck. And then we start having all of these issues that we were talking about related to a tense pelvic floor. So pelvic pain, difficulty emptying bowels and bladder, things like that. So we don't want to Kegel ourselves into a different problem.
That is a quotable quote. That needs to go on a t-shirt.
Yeah.
We don't want to Kegel ourselves into a different pelvic floor problem. That's amazing. I can see some content coming out later today with that.
There you go.
Okay, next. Oh, I just talked about this. Leaking after childbirth is normal, so just deal with it. I know, deep breath.
I'm like, deep breath, because again, there's so many things that are just so normalized in our society, right? We're expected to just pivot all of our energy to taking care of, this newborn baby. And then, but at the same time, we're expected to bounce back and be in our same shape that we were in before we had kids.
Yeah.
But the thing that no one talks about, right, is as you're getting back into exercising, are you peeing your pants? Right? Because that's going to be a barrier for a lot of people returning to exercise if they feel like they, are going to leak through to their outerwear, or if they feel like they smell. And so it becomes kind of this silent thing that a lot of people don't feel comfortable bringing up. Yeah. And when they do bring it up, sometimes they get hit with this rhetoric of, oh, well, you had a baby. That's just how it is. So then these people are just not going to exercise. They're not going to, they're going to limit their travel if they feel like they can't have access to a bathroom. There's like all of these little ways that it starts to impact you, instead of saying, there are very conservative things that we can do to try to address some of this. So.
Yeah, thank you. So it's so seek help, ask questions. And if your doctor says, oh, it's just normal, or just do Kegels, if that doesn't work for you, like ask for a referral. Does that seem appropriate?
Yeah, totally.
Yeah, because I see content out there too where, you imagine like women, having coffee and they start laughing, and then they laugh about how they all just leaked a little bit, like while they were laughing, and sort of normalizing it. Like I appreciate that because people are talking about it. You're reducing shame, but also that can also add to the fact of, oh, that's just normal and you should just accept it. And I just, I'd like to educate on that. So thank you.
No, totally. I was going to say, I saw it was like a Katherine Heigl ad for poise pads the other day as like a TikTok ad. And I was like, I appreciate the message that you're trying to say here, but like, I don't like it in the context of, well, I'm just going to slap on a pad and just, that's just how it's going to be.
Right. Oh, wow. Yes. I can look at that in two different ways. Exactly what you said. Like, oh my gosh, I love Katherine Heigl. Like, that's so great that she's like talking about that and breaking down shame around it. But wait a minute. Like, there's more that you can do for that. Okay. Wow. Thank you for sharing that. Okay. On the same lines, painful sex is normal. So just deal with it.
Painful sex is not normal, not even your first time. Okay. And I get into arguments with people on the internet about this all the time.
Good for you.
Because again, it's like, if this was something that was expected to be painful, it would not be nearly as popular of an activity.
Excellent point. Noted.
So there are things that we can do. We want to find out why this is happening, right? Sometimes it's a muscular issue and it's something that pelvic PT can treat. Sometimes it's a hormonal issue, even if, you're not in like the menopausal state. Sometimes you can have kind of that like de-estrogenized vulvar tissue that can create that kind of rippy, burny sensation. It's also not normal. I mean, I see it a lot of times in people who are taking like oral contraceptive pills, and they'll have some of those vulvar changes, and they don't bring it up. They're just like, oh, well, I guess this is just how it is. And there's, these are conversations that we need to have so that people aren't just, gritting and bearing it or avoiding sexual activity altogether. This is supposed to be something that is enjoyable to people. And so it's important to really have these conversations.
Yeah. So it can be, tightening or vaginismus or pelvic floor. It can be lubrication, sort of a low estrogen state.
It can be scar tissue after a vaginal delivery. Or even, I mean, honestly, so I've had people who have had C-sections who have pain with sex after. And sometimes that's like, abdominal guarding around their C-section scar that's then kind of upregulating their pelvic floor. But then also you have to think like, even if you have a C-section, your pelvic floor still went through a lot just carrying that pregnancy.
Yeah, absolutely. Okay, that's really great. So again, don't accept it as just normal, like seek help. Awesome.
Exactly.
And if you're getting dismissed by your provider, ask somebody else,
Yes.
get a second opinion. Okay, awesome. Thank you. Okay, surgery is the only option for incontinence.
No. We just talked about, the things that pelvic floor therapy can do to try to help incontinence. But even like saying, okay, that's one end of the spectrum, and then surgery is the complete other end of the spectrum. There's a lot of stuff that kind of falls in between there, right? The thing that I feel like people dismiss pretty often are things like pessaries, which can be really helpful across the age spectrum. That's not just for old ladies that can't have surgery.
Well, tell listeners what a pessary is, because I bet there's a lot of people that don't know what it is.
That's really fair. So a pessary is basically, think about it like an orthotic for your vagina. So you can insert this small, usually like silicone plastic device that basically helps to kind of align everything internally. So if you have, a small prolapse or something that might be contributing to why you're leaking, or if you have, something happening like with the urethra, it can help to just kind of give you a little bit of support so that your pelvic floor muscles can work more optimally. All those other systems can, do their jobs. And that can be used long term. It can be used alongside pelvic floor therapy. It can be used as a precursor to eventually having surgery. It's this nice kind of middle ground that can be used for a lot of different circumstances. So it's certainly not just like surgery or bust.
Yeah, that's really great. That's really helpful. Okay, last myth to bust. Men do not get pelvic floor dysfunction.
I mean, I would even go so far to say a lot of people don't even know that men have pelvic floors. So.
Great. Yeah, I mean, truly. Yeah, you're exactly right.
So the pelvic floor, again, exists in the same spot. So it's running from the pubic bone all the way up underneath to the tailbone. So for men, a lot of times it will present as prostatitis, quote unquote, where they'll have pain in the perineum, pain in the genitals. They'll have difficulty emptying bowels or bladder, or they'll have
pain with ejaculation.
And then
they're
absolutely
embarrassed about it. They don't even want to tell their doctors about it. Yeah.
Oh my gosh. I mean, it's one of those things where now actually I will say that I feel like guys will put up with certain things and just won't talk about it because they're embarrassed about it. But like when something starts to go wrong with their junk, they're like, no, I need this better today, yesterday. This is not supposed to happen to me. Because I think a lot of it is they're not socially conditioned to expect a lot of pelvic floor issues. And so when something goes wrong, they're like, we need to take care of this. This is my manhood, right? I mean, so it's like the one time where I'm like, all right, let the toxic masculinity work for you and get the help that you need.
I love it. Yep. That's great. We need to pass that on to women. Like, no, this is not okay. This is not working. We need to fix this.
I've had a few people that have shown up where it's like, I will be treating the husband and he's telling me about, his wife's pelvic floor issues. I'm like, why aren't y'all both in here? Like I could see you at 9 and her at 10 or vice versa.
And then they can help each other with the exercises at home. Oh,
there's a lot of overlap. Great. Yeah.
Couples PT. I think you're onto something.
There you go.
Oh my gosh. This has been so informative and so educational, just like everything that you share on social media and your incredible book. Is there anything else you'd like to share, Alicia?
I want people to know that they're not alone in this, that this is something that is really common, but it's not normal. And it doesn't have to be the way that you live the rest of your life. We want to make sure that we're giving people the resources to, not let pelvic floor dysfunction kind of rob them of those little joys of working out the way that they want to, or traveling the way that they want to, or engaging in sexual activity the way that they want to. Like, you have the power to address a lot of these things. It just takes that first step.
Yeah, that's fantastic. And honestly, I think reading your book is an excellent first step. How can people find it?
Yeah, so Power to the Pelvis is available through major retailers. So you can find it in your local Barnes & Noble. You can find it on Amazon. You can find it through your local indie bookseller, as well as on bookshop.org.
That's fantastic. And how else can people find you?
So I am on the internet as at the Pelvic Dance Floor on both Instagram and TikTok. And I also have a website, thepelvicdancefloor.com.
Fantastic. Alicia, I cannot thank you enough.
Thank you so much for having me. This has been so fun.
I hope you enjoyed this episode, and I hope you learned a lot about pelvic floor health from Alicia today. I want you to take away knowledge of the many common and uncommon symptoms that can show up and some of the benefits of pelvic physical therapy. Thank you for being here today. If you found this especially valuable, be sure and share this episode with a friend. Be sure and follow the show wherever you're listening. Rate and review. It really helps others find the show. Thank you so much to my team at Audiotocracy for producing the show. You can find this episode and all others on my website, drlorashahine.com. Thank you so much for being here today. And until next week, stay brave and curious.